Good afternoon, one and all. I am Dr. Asavri Sawant, and it is a privilege to welcome you to the live panel discussion on episode 2 of Early Signs and Symptoms and Screening Guidelines of colon cancer in Indian perspective on behalf of Voice of Healthcare powered by Zydus. Did you know that colorectal cancer stands to be the third most common cancer among men worldwide in India? Colon cancer cases are amongst top 5 most frequent cases reported. The month of March is observed as Colorectal Cancer Awareness Month. It is observed to make people aware that colorectal cancer can happen to both men and women. It is important for individuals to learn about the prevention, management, and treatment options of colorectal cancer. So, today, Voice of Healthcare, in association with Zydus, has taken up this initiative to contribute our bit towards this global drive of spreading awareness on this very sensitive subject. Let us start the session by inviting some very eminent people from this field. I welcome Dr. Vedant Kabra, Principal Director of Surgical Oncology at Fortis Memorial Research Institute, Gurugram. Welcome, sir.
Thank you, Dr. Shabri.
Next, I'd like to welcome Dr. Shyam Aggarwal, who is the Chairman and Director of Department of Oncology at Sri Ganga Ram Hospital, New Delhi. Welcome, sir. Next, I'd also like to welcome Dr. Rohit Kumar, Consultant of Surgical Oncology at Manipal Comprehensive Cancer Center at Manipal Hospitals, Sarjapur. Welcome.
Thank you, Dr.
Next, I take this opportunity to invite Dr. P.S. Dattatreya, Director and Chief of Medical Oncology Services at Renova Saumya Comprehensive Cancer Care Center in Telangana. Welcome, sir.
Hello, everyone.
Hello. Next, I would also like to welcome Ms. Dimple Parmar, who is the founder and Chief Executive Officer of 𝐿𝐻𝐿 and Love Heal Cancer. Welcome, ma'am.
Thank you so much, Dr. Sawant. Thanks a lot.
Dr. Vedant Kabra will be leading this session for us today. So over to you now, sir.
Thank you, Dr. Sawant. And you have rightly mentioned, this is a colorectal cancer awareness month. And unfortunately, not only in India, but I think worldwide, especially in countries like India, there is a problem about disease awareness in general, and cancer is no exception. Although there is a lot of fear and sometimes even stigma attached to cancer, still people do not have that kind of awareness. Even if they have awareness, they somehow don't come forth for screening or for diagnosing their diseases when they are having some symptoms which may be suggestive of cancer. So our endeavor would be to discuss various modalities of screening. How can we detect early? What are the early symptoms? What are India's specific guidelines, and what can be done for Indian population in particular? And towards the end, we will also talk about colorectal cancer prevention. So without any further delay, I would like to start with involving Dr. Shyam Aggarwal and ask him, what is the burden of colorectal cancer in India? What is colorectal cancer in simple words, how to explain to people, and what are the early signs and symptoms of colorectal cancer? Dr. Shyam Aggarwal, please.
Thank you, Dr. Vedant, and good afternoon to everyone. So, since this is addressed to lay people, so colon is a large intestine where food, after having been digested in the small intestine, traverses through the right side of the colon, then the transverse colon, and then the descending colon. And before we defecate, the rectum is the last part of the large intestine. So any tumor or any cancer which is arising in the large intestine or rectum would be defined as colorectal cancer. So as regards the incidence of or the burden of colorectal cancer, So I was looking at some of the old data and old slides to give you the perspective. So, for example, in 2001, or maybe in that era, colorectal cancer was not even in the first 10 cancers of in India. Although world over, especially in the Western countries, colorectal cancer is fairly common. But now, as it has evolved, because we have progressed economically, and I think that will be discussed, that our dietary habits and our lifestyles have changed. So colorectal cancer burden is increasing each year. And to give you the figures, for example, 2 years back, if you look at colorectal cancer burden, so nearly 65,000 new cases of colorectal cancer would be diagnosed, and the incidence is slightly, higher in males than as compared to females. Just to give you the figures, nearly 37,000 new cases of colorectal cancer will be diagnosed in males, and approximately 28,000 new cases will be in the females. Now, if you look at the distribution between colon cancer and the rectum cancer, so colon cancer is slightly more common than as compared to rectum cancer. 30,000 or 35,000 for colon cancer and nearly 25,000 for rectum cancer. Now, if you look at the deaths occurring from colorectal cancer, so out of 37 or 38,000 colorectal cancers, nearly 28,000 deaths will happen every year. So almost 80% or in that range. So that tells us that majority of these cancers of colon and rectum are diagnosed in late stages, and that is why we are not able to perhaps cure majority of them. And if you look at the cure rates for stage 1, 2, the cure rates are more than 80% or 75%. But the burden is, because of the death burden is because most of the colon cancers are diagnosed in late stages. So if you look at the prevalence figures for colorectal cancer, that will be, the number of people existing at any given point in time with colorectal cancer would be in the vicinity of 80,000 or so. So the other interesting part of colorectal cancer in our country, vis-a-vis incidence, is that Mizoram, and if you look down south in Kochi areas, the incidences are very, very high. So nearly, in Mizoram, Aggarwal area, or even Meghalaya and certain belts of Assam, 1 in 5 in their lifetime will suffer from colorectal cancer, which is a very, very high figure. And similarly, the data from south states, southern states like Kochi and down south, the incidence is higher than as compared to northern countries. So why is it that the incidence is high in those cities and those states is not clear, but I think the consumption of red meat does contribute to that, as for the Western countries, and you need to look into the statistics and epidemiology and design your screening strategies where the incidence would be high, especially in the northeast and in the southern belt. Now coming to your question of what are the early signs and symptoms of colorectal cancer. So any symptom, and that's the general statement for cancer, if it persists beyond 3 weeks, in spite of having taken advice from a suitable specialist, whether it is an internist or a gastroenterologist, one should have the index of suspicion that this could be cancer. So one common symptom which we see is drop in hemoglobin, which is persistent, and that is associated with black stools or blood in the stools, especially if it is a rectum or a lower intestinal cancer. So if anybody has blood in the stool or alteration in the color of stool that could be, be suspected to be having a colon or a rectum cancer. The third symptom would be alteration in the bowel habits. Anybody who starts getting frequent bouts of loose stools or constipation, so which was not there and which is persisting for, as I said, 3 weeks and beyond. I think one should seriously think in terms of going to a doctor for specific investigations. Weight loss is an important feature of any cancer, including colon or rectum cancer. Vague persistent pain in the flanks of the abdomen could also be a feature with which patients can present. And then, of course, if somebody has late disease, patients can have loss of appetite, or if the disease has traveled to other parts of the body, for example, lungs or bones, one could have cough or bone pain, etc. So I think, but I think the most important thing is if your symptoms in the abdomen, vague dyspepsia, etc., are persistent for more than 2-3 weeks, you need to go to a local physician or a gastroenterologist for thorough evaluation.
Very valid and very pertinent points, Dr. Aggarwal, and thank you. I would just like to add a few things. Many a times patients would say, doctor, I'm having gas, I'm having indigestion, and which Dr. Aggarwal mentioned also as dyspepsia. Please do not ignore them. You can't just take a pantoprazole or antacid and you feel good for a few days, again it starts occurring. That's a very common scenario, not only for colorectal cancer, but for other abdominal cancers also. So as Dr. Aggarwal very rightly pointed out, anything which is existing and continuing beyond 3 weeks of reasonable investigations and treatment should be investigated even further. And that's the key to it. You cannot ignore any abnormal symptom. And that is not to say that blood in stool is always colorectal cancer. Dyspepsia or excessive gas or bloating is always colorectal or any other cancer. But there is something wrong happening in your body. Most of the time, it would turn out to be irritable bowel syndrome. But just diagnosing it, treating it, getting okay, and getting symptoms again, you need to undergo blood test, stool test, maybe colonoscopy. All those things stepwise have to be done. So I will now move on to our next
If
question.
I can come in, sir, just a minute. Sorry,
yes.
sir.
Yes, Dr. Rohit, please.
Yeah,
please.
sir. Nothing. Just wanted to stress the recent things what sir also stressed so much. Shyam Aggarwal sir stressed so much. The one important thing what I was looking through was the recent abstracts format, which many of them are published in ASCO 2020 recently also, which has been the talking trend all over the world about increase in the incidence of young adult onset colorectal cancers, which has seen a very rapid rise. In our own published data of abstract that was published in ASCO 2020, we nearly saw the young adult colorectal cancers less than 50 years rise in nearly 50% increase in incidence rates in males, especially in males. So all over the world, we have seen that in less than young adults have the rates are increasing in young adults, whereas in elderly the rates are little coming down because of screening protocols, which we will eventually talk. But just to stress that point of increasing in colorectal cancers in young adults, which has become a talking trend in many places all over the world.
So that's another very saddening statistic, and not only colorectal cancer, but many other cancers. And especially if you compare Indian statistics with the Western statistics, you will find on an average, the peak incidence happens around a decade earlier for most of the cancers. So
Yes.
that's quite sad, and it further gives more impetus that we should be promoting cancer awareness and cancer screening wherever it is appropriate. Now moving on to Dr. Dattatreya from Telangana. Dr. Dattatreya, I would like to ask you, what are the recommended screening guidelines specific to India, and what are the different screening methods available for our population?
Thank you very much, sir. As you rightly made the transition from the incidence to the screening part very effectively, I think we all should know that screening is used to look for cancer before you have any symptoms or signs. scientists, researchers, and medical doctors have developed and are continuing to develop tests which can be used to screen a person for specific types of cancer before the signs or symptoms appear. So the overall goals of screening for cancer, colon cancer or any other cancer, are two sum. Number one, lower the number of people who die from the disease or eliminate deaths from the cancer altogether. And number two, lower the number of people who develop the disease. So these are the two important goals of any cancer screening, and it applies very aptly to colon cancer or large bowel cancer. Yes, as Sir rightly mentioned, different organizations have come up with different recommendations for colon cancer screening, but by and large, for people who have an average risk, when I say average risk, it means that they don't have family history of disease, they don't have any syndrome, which means a collection of some signs or symptoms like a Lynch syndrome, which is commonly a, 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 a factor where these patients have a higher chance of getting colon cancer, or inflammatory bowel disease. And lastly, if they don't have a personal history of colon cancer in the past. So if these four things are not there, then it's more like an average risk, and that applies to almost the majority of the population. Then you can do some investigations for screening. Now, we know that for colon cancer, screening is so effective because this disease follows a sequence of events and doesn't turn into cancer overnight. A precancerous condition by name polyps are present, which gradually go over many years to gradually become or transform to an invasive cancer. So you can do investigations which can diagnose both polyps and cancer. For instance, a flexible sigmoidoscopy is basically an outpatient office test done by a colonoscopist or a gastroenterologist every 5 years or every 10 years. You can do a stool test, which is test the stool for occult blood, and overt blood, which means blood which is obvious, should not. And obviously, as Shyam Aggarwal sir rightly mentioned, we have to make sure that any symptom which is deviant from the body should not be neglected. Otherwise, an occult blood means you are losing blood, but on these stools you can't overtly find the blood. So doing a stool occult blood test every year, a flexible sigmoidoscopy every 5 years, and a colonoscopy every 10 years would be able to identify not only the polyps but also cancer in very early stage. There are some specialized tests as well. I think for India, these three investigations are very, very apt. But what most important is to make sure that any symptom or any sign the body is sending you some signals which is not recovering in a few weeks' time, should make sure that you take the consultation of your doctor. Now, because in India, I think the younger people are gradually showing a more higher incidence of colon cancer. And so I feel that the screening should possibly start at the age of 45 years and not 50 years. Now, this is not fully embraced across all guidelines across the world. So I would say 45 to 50 years is the age where an average a risk of colon cancer individual should get these investigations done. So which means, what do we do if a patient has a personal history of colon cancer or adenomatous polyp, or a strong family history of colon cancer, especially in the first degree relative, which means that a parent, a sibling, or a child, or something called as chronic inflammatory bowel disease, or a family history of a disease which can pass on to generations, then the screening should happen early on, 10 years earlier than otherwise, and the screening should also happen more often. I think this is what I would like to convey to all of the audience today, that screening is the best way to prevent cancer and probably to diagnose precancerous conditions. Thank you so much, sir.
Thank you, Dr. Dattatreya, for making these points. And so the problem is, in general, although Dr. Aggarwal pointed out that it has increased, the incidence has increased, but in general, even now in India, the incidence of colorectal cancer is much less as compared to Western countries. So do we screen large chunk of population? We do a specific target wise screening? How do we proceed? Because there are some proponents of no colorectal cancer screening in India because of these reasons, as well as there are certain other reasons. We do colonoscopy. Before colonoscopy, we need to prepare our intestines by giving some laxatives. If the bowel preparation or intestinal preparation is not very good, those small adenomas or polyps can be missed. And compliance is also a big issue everywhere, including in India. So there are certain issues which some of the experts believe that it is not routinely recommended or not to be recommended across the country. But as we were discussing just before starting this panel discussion, it is important that we should make people aware. We should encourage them to screen because the incidence is rising. The patients are younger in India, and as you very rightly pointed out, those who have more genetic predisposition should start it a little early. Dr. Rohit,
Sir, just one last comment
yeah,
for the audience.
yes,
I
yes,
mean, if there's one thing that the pandemic year of 2020 and 2021 has taught all of us, it's that we cannot take our health for granted. So whenever
absolutely.
we notice something different about the way our body functions, we must get the attention of our family doctors. Even if it's not something alarming, they may be able to allay our fears. For instance, for
Absolutely.
colon cancer, this small screening test of checking the stools for occult blood once in a year produces a 30% reduction in the incidence of colon cancer and a 18% reduction in the deaths from colon cancer. Now, that's a substantial reduction, and this is strong data, the data which I have told you. Thank you so much.
Absolutely. And the other part that I want to convey, although it is a little different from our topic, is because of the pandemic, you cannot ignore your symptoms which are suggestive of cancer or any such similar disease. We have seen patients waiting in their houses for 3 to 8 months and then coming to us. They were diagnosed with cancers or they were having strong symptoms and they didn't come. And I'm sure all of us have experienced that. Dr. Rohit, can you highlight some of the challenges that you face in applying screening in your patients, in your population, and specifically with regard to our country?
Yes, sir. Thank you, sir. You're taking the questions in such a flow of patterns that it is exactly falling into place. So, as just we are mentioning about pandemic, so we are talking about the C that is happening since last 3 years. Now, COVID, the C, because of which the another C, the dangerous cancer, was neglected, and over that now we have our own C now that we are talking today, that is colorectal cancer. So if we compare the mortality rate in cancer, in the COVID, the mortality rate is around 4% in India maximum. For overall cancer mortality rate in India, it's nearly around 50 to 60%. But as Shyam Aggarwal said, in colorectal cancer, the mortality rate is nearly up to 80%. So such is the damage that it is causing. But still, systematic and community-based screening is still non-existent in India. That is a fact that has to be accepted by all of us because of the numbers that we are always talking about. However, I would want to quote Sidney Winover, who has been considered as the James of colorectal cancer screening, and he was the person who conducted the first study to demonstrate that removing adenomas will reduce the risk of colorectal cancer. And he quotes that the best colorectal cancer screening is the one that is done. That's what he tells. So he tells that any colorectal cancer screening is effective if it is just completed. So when looking into challenges that we are facing at our institutional level, I would want to put it in terms of 3 P's. So it would be in terms of patient perspectives, in terms of physician perspective, and also in terms of policy or organizational perspectives. When you look into patient perspective, what we most commonly see is the knowledge gap. That many of the patients or many of common people are not aware of what are the symptoms that we are discussing today, or what are the techniques that is available
Hello?
to do a screening? Hello, sir. Am I audible? Yeah. So, what are the techniques available to do colorectal cancer screening, and what is the impact that doing a screening has on their life? Just 10 minutes, or just a 50-30 minutes of colorectal cancer screening, and you're peaceful for 10 years. 10 years you're peaceful, you don't have to think anything for 10 years. And how many people really know about this, that if you suffer for just 30 minutes of colorectal cancer colonoscopy, 10 years you're free. So the patient has to be educated is the first, when we look in terms of challenges with respect to patient. When we come, and also in terms of monetary things which many of the insurances don't cover, they have to pay from their pockets. That becomes a very big issue, because screening, any diagnostic procedures are not being paid by the insurances, and they think in terms of money. And last but not the least, let us accept the fact that how many of us would want to have a cancer diagnosis on our face today? We are ready to tell, no, it's okay, even if I don't know, when it comes to me, let it come to me whenever it comes. That is what our attitude is. So the knowledge, attitude, and practice gap is what is the most commonest challenge in our setup. Next is the physician's perspective. In terms of physicians also, there is this knowledge, attitude, and practice gap. So our own physicians, many of them are the primary physicians who come across are the trends of family physicians. How many of us are well educated about the techniques of doing the occult blood test? Previously we used to do a guaiac based blood test. How many of us do a fecal immunochemical test, which sensitivity is increased and it is not affected by the food that we consume or drugs that we consume? With respect to what is the screening timing that is required, and how to assess the risk as such. Matlab, is this a patient average risk one, or is he has a high risk? So this is also a very important thing which physicians fail to address many of the times. And let us not forget, finally, the policy perspectives or the organizational constraints. When we look into our own Indian, our setup, most of it is run by the private institutions or private hospitals, where the cost itself is a very demanding for most of the patients who are affording for screening protocols. Then we come into public institutions or government hospitals. There is lack of facilities. We don't have equipments. So finally, all these things becomes a very big issues. So putting it all together, it's about patient's perspective, physician's perspective, and the policy that we're looking at as a organizations. So these are the challenges which I would look at in our own setup in India, sir.
Rohit very clearly discussed about the importance of the fecal occult blood testing and what is also called as the FIT or the fecal immunochemical test. And it's so important that the point is polyps or cancers that do not bleed continually or continuously. And that's why you must do these tests on the stool samples every year. Now,
Yes.
doing a stool test every year is not a big thing we are asking from any of our patients. What I was trying to tell is that polyps and cancers do not bleed continually, and therefore, doing a fecal blood test every year is like one of the best ways to identify the disease early. And as Rohit rightly mentioned, I mean, colonoscopy, if it comes completely normal, then like for the coming 10 years, you don't really have to worry much because in colon cancers, for it to develop, adenoma carcinoma sequence is there. From polyp to adenoma to carcinoma, a long time happens, and that gives us the important reason why screening works so well in colon cancer. Of all the 200 subtypes of cancer we have, only 4 cancers can be screened. One is breast cancer by clinical examination and mammography. The second is cervical cancer in females by doing a simple test called as pap smear. The third is colon cancer, and we're discussing that important point today. And the last is in males, prostate cancer by doing a simple blood test after 50 years of age called as the serum PSA test. So when these things are so simple and they are not such a burden financially or otherwise, I don't see any reason why these should be disregarded by any of the public who has awareness or who gets educated by such forums as what we are discussing today. Knowledge
Thank
is
you.
power and ignorance is not bliss. Thank you, sir.
Thank you, Dr. Dattatreya. Ignorance can sometimes be bliss, but definitely not here. And I would add one more cancer population, especially oral cancer, which again is very common, can be very easily detected. Now, moving on from physicians to somebody who is not a physician but is involved in healthcare and is helping patients, especially cancer patients, get the right treatment, right advice, and non-medical help as well in recovering and rehabilitation. I welcome Ms. Dimple Parmar, who is founder of zenonco.io, and I would like to ask her. She has seen cancer care from the sides, right? Not being in the forefront of delivering cancer care, but helping the patients. And I would like to ask you, what gaps have you noticed in cancer care in our country? How technology and platform like yours can help in bridging those gaps?
Yeah. Hi, Doctor. Thanks for the wonderful opportunity. I have my founder Kishan also here with me. So, as Doctor rightly said, that colon cancer in young adults are on the rise, and I've gone through the similar journey of from a caregiver perspective, where I lost my late husband Nitesh to colorectal cancer at the age of 25 when he was diagnosed with the disease, and at the age of 27 he passed away. It all happened 4 years back. So when he was diagnosed, like he had side effects, he had symptoms which we ignored because we were not aware that what are the side effects and symptoms that we should not ignore, and the right diagnosis at the right time is very important. So he ignored it for 5 months, 6 months. I've gone through all the constipation and severe weight loss, back pain, and finally when it started bleeding, he went to the hospital, and then after multiple visits, we got to know that he has colon cancer. It's third stage, third advanced stage. So started with the treatment, but unfortunately, his case, the cancer was way too aggressive. And with the treatment, his disease relapsed, and with fourth stage, he had only 6 months to live. So there are definitely what I felt that there are many gaps that though the lot of medical advancements are happening, but still as a caregiver, after even having access to the best network and resources, I felt many gaps in the ecosystem. And I felt that though everybody, all the stakeholders, all the entities are trying their best to improve the cancer care ecosystem, but still there are gaps and there's a long way to go. So after I lost Nitesh, so in between I got married to him, and then we went to the US, hoping that maybe there is some miracle, some clinical trial, some advanced treatment, something will work. And by the time I got in touch with some stage 4 survivors as well, so that gave a ray of hope. But unfortunately, we lost Nitesh 4 years back, and that's where I decided to dedicate my life for this cause. So started Lovell's Cancer, which is an NGO to support cancer patients, and then me and Kishan, we both started zenonco.io. So we'll just also share the way we are using technology to bridge gaps in cancer care ecosystem.
Right. The way we see is that there's a gap on all three fronts: diagnosis, treatment, and post-treatment. And a lot can be done using technology on all these fronts. On the diagnosis side of it, so for example, many times people like us, general public, they don't go for cancer-specific tests simply because there is a hesitation involved over there. And right now, there are different tests for different types of organs as well. While if you look at the new technology which are coming up using big data, using machine learning, we are able to find many of the other CTCs which are indicating the probability of having cancer. For example, OCT4 has been recently discovered, still in clinical trials, very early stages, but still, just by a simple blood sample, we may be able to detect multiple kinds of cancer, colon cancer being one of them. And this reduces that hindrance, that initial resistance that many patients, many public has. Similarly, on the treatment side, many updates are happening. CRISPR technology, which was discovered long time back, 1980s, if I'm not wrong, but significant progress is being made on that front in recent years now, which is more around gene sequence editing and can help us combat many genetic disorders, including cancer. And lastly, on the post-treatment front is where we majorly specialize in. And what we have figured out, what we have found is that there are multiple areas where patients are bit confused, not able to really go navigate through the journey in the right direction. which is where a companion kind of an app, which is where patients get access to a mobile device that guides them 24/7 as to what can be done in their particular phase of journey, their particular treatment phase. Many times patients, they follow what they read on WhatsApp, what they read on different platforms, which causes a lot of confusion as well. For example, many patients that come to us, some of them have been taking, say, wheatgrass while they're on dialysis, and it just worsens the problem because it doesn't go well together because of potassium phosphorus levels. And the answer that they give is that I did this on WhatsApp, and which is why now I started following it. But then if we can provide them a platform where they can search for anything that they have, anything that they consume in their body, whether it is medically approved or not, whether it goes as per science or not, and that can change many things. Another example is very common, curcumin. Many patients take that while they're on chemotherapy treatment. Doesn't go well, doesn't go hand in hand. And when they come to us, maybe the clinical efficiency of the treatment has reduced, and based on all the research papers, they figure out that it is not good to go. If we can provide them a platform where they can themselves search that, does it, my current chemotherapy is this particular thing, say cyclophosphamide, and now I'm taking, say, a particular supplement, does it go hand in hand well together? So those are the areas where we are helping patients, helping them on the entire treatment spectrum, the other questions that they have, be it non-medical or different kinds of questions that they have.
Right. So, in fact, in the patient, what we are also launched a tool called 𝐿𝐴 which is also got recognition at ESMO last year. We launched this during COVID time when a lot of queries around medical treatment and the entire where patients were not able to visit metro cities for the treatment and guidance. So the tool is called 𝐿𝐴, 𝐿𝐴 Integrative Oncology Preliminary Assessment Report, and the tool gives initial direction, an indication that how your treatment is going to be based on the NCC and ESMO protocols, and ultimately it's the oncologist who will decide based on your current condition and different factors. Similarly, we provide community support because what we see, and in fact, I was also looking for is the who else have survived stage 4, 25 years of age, MSS status, colon cancer. And today we get a lot of queries where people are looking for similar cancer type survivors and looking for a community support where they can share, they can discuss, looking for a companion who have gone through the similar journey and can at least guide them when they are lost in this whole new world of cancer. Today, what we are doing, we have developed a tool called Financial Resources. So you enter your profile, and based on that, it will tell you what all government grants, financial resources that you are eligible for based on your family income and which state you belong to and where are you taking treatment from. And similarly, we have also recorded stories of 1,000+ cancer conquerors, cancer survivors, because those are the stories that inspire people when they're looking for people who have survived in a hopeless situation. It gives them a ray of hope that yes, if they can, you can too, because ultimately outcome may be different for different people, but then what really matters is their journey. I had best network, resources, everything, but then still my journey was full of struggles, full of suffering, because I didn't have that kind of understanding, that kind of knowledge, that kind of guidance and support when I was the caregiver. Hence, today with zenonco.io, we want to make it as a one-stop solution where no matter what their needs are, because when they start the medical treatment, the journey starts from there. It doesn't stop there. They look for what to eat, what not to eat, where do I go, how do I find the community support. When they are at end of life care, they look for a palliative care assistance. I know in India, the hospice care, palliative care is not yet that developed as other treatment or other facilities, but still they do look for such support services. And that's where we are using technology to bridge those gaps that, okay, can we really provide, for example, anti-cancer diet. People sometimes pay even 60,000, 1 lakh rupee for anti-cancer diet, and sometimes they're looking for a very affordable solutions on which they can trust, scientific evidence-based solutions. Similarly, we have launched anti-cancer diet app so that and everything is backed by science, because what we are doing is integrative oncology. We need to ensure that whatever complementary therapies we are doing, it's actually complementary and it's not alternative. It goes with the medical treatment depending upon what drugs patient is taking, what chemotherapy, what comorbidities they have, and many different factors. So that ultimately the idea is to improve the clinical efficacy, to manage their side effects, and to improve their quality of life. And that can only happen when we look at this disease from a holistic point of view, taking care of their emotional wellness, connecting them to a psychologist, a cancer survivor who have gone through a similar journey, because they are the best support and caregiver, extended arm of caregiver team basically. So and we are only able to do only because of technology. And I believe that with the help of technology, many of the solutions, even for also 3 P's that we focus on, one is our partners, that are oncologists and hospitals, second is our patients, and third is our people. So I believe that with technology, we can really bridge those gaps. And I love the World Cancer theme this time, which was close the care gap. So this is how Zenonco is trying to close the gaps and bringing all these entities, people, partner, and patients together for the betterment of them. Dr. Kabra, we can't hear you. You're on mute.
Thanks, Dimple and Kishan, and sharing your story as well, your personal story, and compliments to you that in spite of this personal tragedy, you have bounced back in a manner to give it back to society, and so that other patients do not suffer like your husband did or your family has suffered. It's very important. There are certain points that you mentioned about genetic, molecular, artificial intelligence, CTCs. There are many things which are still in experimental phase, and I would like Dr. Shyam Aggarwal to comment on these things and how relevant are they in today's time, and can we practice them in today's time, or are we going to be ready in few more years?
Right, Dr. Vedant. So I think the kind of things you have mentioned or Dimple has mentioned, we are just, starting to understand them and, of course, implement them as well, not only in advanced cancer cases, but I think also in early cases of colon cancer. Just to give you certain examples, if somebody has an early stage colon cancer, in order for us to decide, node negative early stage cancer, which is, invaded the muscle, because these are now you to go into specifics. I'm sorry. Maybe
Right.
the layperson.
A little technical, but I think it's necessary to explain it. Yeah.
Right. So, a simple test called MSI test, which is microsatellite instability, can guide us to decide whether this patient should be given cancer chemotherapy or we can avoid cancer chemotherapy. Similarly, in patients with advanced colorectal cancer patients, we need to perform certain gene testing, which includes, KRAS mutation, NRAS mutation, BRAF mutation, HER2/neu. So several of these tests or few of these tests need to be performed so as to identify the best line of treatment. And these are now commercially available, and all patients of advanced colorectal cancers are getting these tests done. Although I can understand the cost of the targeted therapy, as we call them, in the form of bevacizumab or EGFR inhibitors, are quite expensive. But then these are readily available, not only recently, but I think we've been using these drugs for more than 10 years now. And they have certainly made a dent in the management of advanced colorectal cancers. Earlier, people were, we only had 2 or 3 agents of chemotherapy, but now with the advent of targeted therapy, people are going beyond 2 to 3 years. And more recently, we have the introduction of immune checkpoint inhibitor therapy, although very expensive and limited because, the utility is only in less than 5%. But yes, somebody can be really lucky to get the MSI testing high and then becomes suitable for such tests. So, these are newer areas of research which we have in India. It's not that we are missing something. All the drugs are available, all the technology available. You also mentioned about CTCs, which means circulating tumor cells. So I think that is not routinely practiced at this point in time for current management of colorectal cancers. So I think we are evolving fairly rapidly, and suffice it to say, as I said in the beginning, if you have an early cancer which has been operated and all the tumor has been removed, the cure rates exceed 70 to 80%. So 70 to 80 out of 100 can expect to live a normal life. But patients who have disease which is spread to different organs of the body, for example, lung, liver, bones, etc., people are crossing 3 years, and we are, converting this into a chronic disease. And we have to use these modalities of one chemotherapy, second chemotherapy, targeted therapy in a sequential fashion, because we have 7, 8, 9 drugs today to handle these cancers. So I think things are becoming available. Science is improving, research is there. So we need to be positive whenever we are struck with a diagnosis of cancer.
Very aptly put, Dr. Aggarwal. And you see, the time has come for individualization of treatment. India is a very diverse country. Many people may not be able to afford it, but at the same time, there are many who can afford it, and it should be made available. Not to say that only those who can afford should take it. There has to be some mechanism in helping those who are not able to afford, but they need it, and it will make a significant difference. You said we are able to make now stage 4 patients live 2-3 years. Very limited stage 4 actually can go up to 5-6 years also, and beyond that. So that's how it has changed. But a word of caution: we cannot run after technology all the time. We cannot run after newer advances without being very carefully studying their proven efficacy. So that's very important, and a word of caution, although this is a little out of the way from our topic of discussion. Now, again, Dr. Aggarwal, I'll continue with you only. The utilization of CRC screening, colorectal cancer screening, is much less as compared to breast and cervical cancer. What do you think is the reason? Is it more glamour associated with breast cancer everywhere? Is it something else?
No. It's not a question of glamour. I think the first point is, although the incidence is rising, but it is not, something like what, as I said, is happening in Mizoram or in the southern states. So the incidence is much lower. And second, I think the most important inhibition which people have is that you're looking at an area by, say, a stool test or a fecal test. So I think that is one issue. And secondly, going for a investigation like colonoscopy or sigmoidoscopy every 5 to 10 years, again, I think it needs to be popularized. So it is not acceptable. I was just thinking when Dattatreya and Dr. Rohit were speaking, how many of us doctors after the age of 50 years have undergone a stool test, or for that matter, a colonoscopy? So after 50 years, they recommend it once in 5 to 10 years. And so there is a huge gap there. Maybe NGOs, maybe the government of India, maybe ICMR and so on need to really work hard in pushing people to perform this kind of an investigation. But let me just say one more thing, that people who have a strong family history, for example, if somebody has 2 or 3 relatives, and we have patients like this, so and if somebody has a family member who gets colon cancer under the age of 60 years, so those are people who must go in for the fecal occult blood testing, and for colonoscopy and sigmoidoscopy. I mean, that's a really high risk group, besides the familial situations like HNPCC or Lynch syndrome. But I think we are way away for doing once a year stool test and a colonoscopy after the age of 50 years. We are way off. It's not a question of glamour or anything, but I think just because the tests are not easy. I mean, if you envisage a common man's thinking,
Psyche,
and you tell him, I think you really need to be you really push the people to perform that test.
Absolutely right.
Sir, may I just say a few seconds?
Yes, Dr. Dattatreya, I was
So
about
to
to
just
ask you anyways how to
just
overcome
compliment
these
Shyam
barriers.
Aggarwal sir, as an ending sentence, as he rightly mentioned, the question is not about clamor. The answer lies in generating more clamor.
Yes, you're right. Dr. Rohit, can you mention some of the recent advances that are available in terms of screening and better detection rates in India? Maybe not causing so much of discomfort, or if I may use the word, embarrassment of undergoing colonoscopy or something like that.
Dr. Rohit, we can't hear you. You're on mute.
Oh, sorry. I was discussing with Vedant Kabra sir just before we started also. In our own institute, when we were thinking of looking into cancer screen package, I just went and saw that we are still practicing a stool-occult blood test that is guaiac based, that is almost outdated in most of the Western countries. And that is the basis of doing a screening test for colorectal cancer. And guaiac based stool test, the fecal occult blood test, is disrupted by the food we intake, is disrupted by the drugs we take, and all those things. Whereas the fecal immunochemical test is not disturbed by the food, it is not disturbed by drugs, and it is more sensitive and it is more specific. Although we don't have a randomized control trials to tell about it, the studies are enough to show that it is more efficacious. So now, on my own research protocol, I researched all those things, and we got fecal immunochemical test as a include in cancer screening packages. And what was the cost difference? The cost difference was just 500 rupees. For a fecal guaiac based blood test, it costs around 400 to 500 rupees. For a fecal immunochemical test, it comes around 1000 rupees. And who is not ready to pay? Everybody is ready to pay for 500 rupees extra if they have that satisfaction that no, it is more safer. So fecal immunochemical test is something that has to come to our cancer screening packages. And when we looked into our own neighborhood hospitals, many of the hospitals are still practicing guaiac based test itself. So that is one basic test which most of the hospitals in India should include in the cancer screening packages, which I want to stress here. Then when we look into advances, we have many advances that has been there. Recently, FDA approved a serum-based test, that is a methylated septin-9 DNA assay to assess the risk of colorectal cancer. We also have many genetic.
Dr. Rohit, let's talk about something which is available in India.
Yes. So in India, as such, the most important thing what I would stress is to stress about fecal immunochemical test. Apart from that, there are many multigenal plant tests and all those tests, but this is the basis which I would depend on everything. And then we can, as a physicians, we should look into assessing the colorectal risk scores, like the E score, which depends upon environmental factors, lifestyle factors, and germline factors, through which we can assess the risk and segregate the patients and tell them, okay, your risk is more, you need to be more intensive. Your risk is less. Yes,
we can tailor make the
screening should go at. Yes, we should concentrate on learning more on colorectal risk assessment scores, which is evidence-based, and then apply those tests into our own population.
So before I move ahead, any comment from Dr. Dattatreya or Dr. Aggarwal regarding barriers, regarding any recent tests and how to overcome these barriers for screening? Otherwise, I'll move on to the next question. Okay, so yeah, Dimple, I would again come to you now. How can we provide quality integrative oncology accessible to everybody in our country? You did mention about it, but any specific points, and very briefly, because we are now reaching our end time.
Right, definitely. So when we talk about integrative oncology, it is a patient-centered, evidence-informed field of cancer care, where we utilize different kind of practices together, which is evidence-based, which goes along with the medical treatment to get the best outcome, and aim is to optimize health, quality of life, and clinical outcome for patients. When we talk about a country like India, we see that many times patients are misguided by different quacks in the different corners of the country, where they really, because patients are also very desperate, they go for any kind of treatment, therapy, anything that they see available out there, and also listening to the fellow caregivers or other patients from different kind of forums and communities, and that's where it backfires. So it's always very important that we go to a very skilled healthcare professional who knows what is integrative cancer care, who knows that what this means to combine different modalities together. So no matter where or how it is practiced, integrative oncology care requires a team of knowledgeable and skilled professionals who work collaboratively, who communicate with each other and respect each other's contribution to the for the care of the person who is going from cancer. When we talk about India, there are some experts who are taking scientific approach, no matter if they're talking about dietary approach or even when we talk about diet. or any other different form of, let's say people talk about medical cannabis, which is prescribed by a doctor only, and which is approved by government of India. I have seen people taking it when they are on immunotherapy, and science says that it clashes with immunotherapy. You shouldn't be taking it, and that's where I think the prescription from a doctor advice really comes into play, that we need to, even if we are combining different form of therapies together, it needs to go hand in hand. Now, when you talk about integrative therapies, there are two kind of it. One which is intangible, for example, meditation, yoga, healing, energy therapies, exercise, movement therapies, sleeping well, creating healing environment. Well, there are other tangible things in which you need to eat something, which can be supplements, nutraceuticals, Ayurveda, or any other traditional medicines. Now, that's where we need to be very cautious, that even if when we are taking different form of traditional therapies or medicines, are there any heavy metals in it? What is the scientific backing? Are there any clinical paper published on that? And that's
Yeah,
why
Dimple, could you please very briefly give pointers because we have limited time? Just give the pointer. So as I understand, it has to be not only allopathic medicine. We can integrate other areas, what we call as holistic medicine. We can take good part from every area of medicine, whether it is homeopathy or it is Ayurvedic or Unani or other things. It has to be backed by a research. Obviously, it should be backed by a solid research, and then we should integrate everything. And our
Yes.
age-old meditation, yoga practices. So not to say that these are going to cure cancers, but these are going to have a healthy lifestyle to prevent cancers, to maybe prevent recurrences, to tolerate the treatment better, to have lesser side effects. Yes, all these things are very important. And integration of oncology in every field of medicine, from different fields of medicine, is very important. Dr. Rohit and Dr. Dattatreya, your very brief points about integrative oncology. Dr. Dattatreya first, and then Dr. Rohit.
As you rightly mentioned, sir, from my side, the take-home message would be these branches complement each other, and with regard to the modern medicine, these integration of the other branches also supplement each other. So they are complementary and supplementary.
Absolutely. Thank you so much. Dr. Rohit, your brief
Yes, sir. So I
comment.
talk
Yeah.
all our patients in only based on these four pillars, which I believe for is required for treatments and for patients: food, exercise, sleep, and then stress by meditation. So this always forms a core concepts of handling any patients or individual our life as such. But these are only to prepare us for things. For acute situations, we have to be backed up with our allopathic medicines. So this is integrated. That is what, as all of you are telling, has to be complementary, and this will be a supplementary.
Absolutely bang on, Dr. Rohit. And so I would like to summarize at the end what we have discussed so far. This is very important because colorectal cancer incidence is rising world over as well as in India as our lifestyle is changing. We used to have much less stressful life earlier. We were eating homemade food, freshly made food, what was recommended by our grandparents like dadis and nanis, dadi ke nuske, right? Nani ke nuske, all those things. We have moved away, and it is showing up in data. Dr. Shyam Aggarwal mentioned from 2001, when it was not in first 10 cancers, now it has come in first 5 cancers. Almost 70,000 new patients, 80% mortality, because we are not catching them early enough. And there are various reasons. Probably the most important is less and less awareness. Yes, non-availability of care, non-availability of resources, affordability, all those problems also add to it. We have certain pockets which have very high incidence, and Northeast particularly, if you see, lifestyle associated diseases are very high in northeastern states. Similarly, in southern states also, colorectal cancer is very high. Screening is a very, very important tool. And just because colorectal cancers still are less common as compared to Western countries, we cannot say that screening is not useful in India. We have to make people aware about it. We have to select the population and then screen them selectively. As we also talked about, that colorectal cancer patients are getting younger and younger. So at younger age, and Dimple is here. An example, right? Her husband had it at the age of 25, which is very young. And in India, we are seeing most of the cancers occurring almost a decade earlier as compared to our Western counterparts. Screening can be done by various tests, very simple stool test, DNA-based tests, colonoscopy. Colonoscopy can be actual or virtual. Virtual in the sense it is a CT scan-based colonoscopy. It has its own merits and demerits. And I think there are special populations. So those who have much higher risk of developing colon cancer because of some genetic predisposition, because of certain syndromes, we must start screening 10 years before the youngest family member who has had cancer. So somebody who had cancer at the age of 30 and there is genetic predisposition, we should start screening for those who are at higher risk at the age of 20. That is how it should be done. There is new research coming for screening, for treatment. Treatment is not the topic of discussion for today. And very important is prevention. Let me tell you, it is not only colorectal cancer. Almost 50 to 60% cancers can be prevented if lifestyle can be perfect. So obviously it's difficult to achieve perfection, but we can improve that. And my take is how to improve that. Dr. Rohit very beautifully said 3-4 points like food, exercise, meditation, stress. And I would also like to say holistic health, like holistic care, holistic health. It is not only your physical health which is important. It is your mental health and your spiritual health, which would encompass everything. In physical health, diet. People say you are what you eat. So your diet has to be proper. Fresh fruits, veggies, ample amount, fiber in diet. Avoid red meat. It is very well shown that high amount of red meat increases not only colon cancers, but other cancers also. Red meat eaters, and if I may say so, non-vegetarians at large live shorter as compared to vegetarians. There are some studies across the globe, but red meat definitely has been shown, proven to be increasing colorectal cancer incidence. Similarly, if we are not exercising regularly, we are obese, we are having certain habits like excessive use or use of tobacco and alcohol. There is nothing like excess use. Even a little amount of use of tobacco and alcohol is not good. Certain deficiencies, and especially for colorectal cancer, vitamin D deficiency. These are certain factors which can help you prevent colorectal cancer. And finally, integrative oncology, which all of us agree that we cannot work in silos. In today's time, an engineer cannot remain an engineer and a biologist cannot remain a biologist only. The advancements in science have only happened when multiple areas have come together. For a man to go in space, not only engineering marvels are required, but a lot of medical inputs are required, because a person has to live in space which is zero gravity area. So for any advancement, I think integration of multiple specialties is needed, and that is true also for integrative oncology. Holistic care, taking good points from everywhere. As Dr. Rohit mentioned, acute care, we must do it. We cannot rely on certain things which have long-term effects, which are very slow incremental effects over the years, because all that has happened in a bad way. Now to correct it will take many years. So acute stage has to be treated in probably a modern medicine or allopathy medicine way. You should add other therapies as well, which are not in contradiction. Please discuss with your doctor. Don't take anything which is not gelling or not compatible with your treatment of allopathy. And be aware of quacks. There are many practitioners who would give you medicine, who would guarantee many things, and they actually contain steroids and heavy metals. Please be aware of all those things. And I thank everybody, Dr. Shyam Aggarwal, Dr. Dattatreya, Dr. Rohit, Ms. Dimple, and Voice of Healthcare for giving us this opportunity to bring out our thoughts and spread awareness. Thank you very much.